talk to all of you here at MEDIPATH. Thanks for putting this all together, to Shelley and the MEDIPATH team. We've all been very excited and looking forward to this event for the past several months. So hello, everyone. As Shelley said, I'm Sarah. I'm one of the chief residents here at Morristown and ER, and I will be talking to you guys today about basic life support and advanced cardiac life support. Okay, so the learning objectives that we'll go over today is just understanding the importance of basic life support and really the chain of survival, understanding those critical steps, learning how to perform high quality CPR, and learning how to apply and use an AED, learning how to perform the Heimlich maneuver, and understanding just the basics of advanced cardiac life support. So why is this important? So basic life support is extremely important because it really saves lives. About 400,000 cardiac arrests are estimated per year in the United States. A lot of times these happen suddenly and outside of the hospital. CPR has been shown to not double but triple, in most instances, the survival of adult patients who have out of hospital CPR. So recognizing a sudden cardiac arrest and intervening quickly makes a huge difference in these patients' survival chances. And if you act really quick, at least 4 minutes without oxygen can lead to permanent brain damage. So 4 minutes isn't really a long time. So it's really important to identify this really quickly and act as soon as we can. 8 to 10 minutes without oxygen can really be lethal and can lead to death. You're not perfusing one of the major organs of your brain. And about 89% of the out-of-hospital cardiac arrests patients will die if there's no CPR that's started at the scene. So this is really important for us, and a lot of cases of CPR or witnessed arrests happen to be family members. I think the estimate was about almost a quarter of all the arrests that we'll experience will be a family member. So even more important to make sure we're aware of this. So just going over the chain of survival, this is huge, and these are the different steps that providers or person in public should go through to be able to successfully resuscitate a patient and bring them back to the hospital. So just basically going over the steps. So the first step for any person out in public that sees a sudden cardiac arrest, just recognizing the cardiac arrest, activating the emergency response system, getting help, asking somebody to grab the AED and call 911, starting CPR immediately, placing the AED pads, administering early defibrillation if it's indicated, and having EMS arrive, kind of resume care, intubate the patient if necessary, kind of understand maybe what the cause of the cardiac arrest is, and early identification of that can all improve the patient's outcome by bringing them to the hospital, and having the hospital be aware of what's coming in early and leading them to the care that they need. So this chain of survival is huge, and you'll see me reference it a few times throughout this lecture. So we're going to make this interactive. We'll start off with a clinical scenario. I guess you guys can type in the chat. I think I'm able to see that, right, Shelley? I should be able to.
As I unmute myself, yes.
Okay, perfect. So this, happens. So say that you are at a supermarket, you're in line waiting to pay for your groceries, and the person in front of you just collapses to the ground. What do you want to do? Anything that you're concerned about? What would you do?
I also made a poll everywhere. So on that link that everyone has, you could put it in and see your responses coming up live in the PowerPoint.
No, there's no pressure. Perfect. Obviously, you want to check for a pulse. Yes, great. Check to see if he's breathing. Vitals, okay. Perfect. Absolutely. These are all fantastic responses. Okay, see if there's any bleeding. Fantastic.
A to E. That's a good one.
Yes. Talk to them. Yeah. Perfect. Yep. You guys are rock stars. ABCs. Absolutely. Perfect. So I think you guys identified, some of the key things that we want to do. Another important thing to notify with scene is to make sure that it's safe. So in this instance, you were at the grocery store and you saw the person collapse in front of you, but say you're a bystander walking into a parking lot and you see multiple people found down on the ground unresponsive. That may indicate to you that there is either maybe some kind of like lethal gas or something around. So you wouldn't want to put yourself in this scenario where you could be at risk for exposure to some kind of toxin, or if you're at a scene and there's an active shooter, there's a lot of people unfortunately shot on the ground and somebody is running around, you may not want to run out and yourself be at risk for being shot. So one of the most important things that you want to do first is check scene safety to make sure that it's safe for you to intervene. All right. And when you say you verify the scene is safe, you can go and check the victim, like you said. You can see if they're breathing, check if they have a pulse. That's excellent. And then you want to shout for help. If there's anybody around, you can shout for help. You can ask a bystander, say, I need help. This person is unresponsive. Can you usually want to tell them to call 911 and get an AED. And the most important thing as well is to ask them to come back. Sometimes you'll ask for help, and the person that you ask for help will go and do that, but they may not come back. So it's hard for you to know if they actually were able to go ahead and do that successfully. If not, then you need to try and find someone else to help, or after a few minutes of trying to resuscitate the patient, you then need to try and ask for help. And then activating the emergency response system, applying the AED, and getting any kind of emergent equipment. So as you guys brought up excellently, that we should check for breathing and a pulse in this patient. So for checking a pulse, you can check their radial pulse here in the wrist. You can check their carotid pulse here in the neck to see if you feel a pulse. As far as breathing, you can kind of examine the patient. You can kind of see if you're seeing any chest rise. You can kind of come close to their mouth, see if you're seeing any kind of breathing. To assess for what to do next. So say you evaluate the patient, you see that they're breathing normally and a pulse is present. What you can do is just stay with the patient, monitor them until EMS is there and help gets there, and you can kind of help fill them in with what happened. If the patient's breathing is abnormal and a pulse is present, you want to move forward with providing some rescue breaths. That's very important. If the patient is breathing abnormally and the pulse is absent, you want to go ahead and start CPR. So we're going to bring it back to our patient, the gentleman that collapsed right in front of us in the supermarket. So we verified our scene safety. We're not concerned for any kind of toxic, exposure or any kind of, active shooter or anything like that. We had asked the person behind us to go call for help and to go get an AED and come back. And by doing that, you have already started activating the emergency response system. You've already begun to start that chain of survival for our patient. So while you initially saw that their breathing was abnormal and that they had a, sorry, the screen is a little covered. Okay, so then you evaluate the patient, you find that they have a pulse and they're not breathing well, what would you want to do?
Not sure if I did a poll everywhere for this one. Hold on, I might have. No, yep. No sneak peeks. But guys, you can write in the chat box. You'll see it directly in Zoom. So write what you would do next. I think maybe because I gave away the answer.
Perfect. That is fantastic. Yes. So, like you said in the chart, you want to go ahead and do some rescue breathing because we identified that they had a pulse, but their breathing was abnormal. So, rescue breathing, this is a really important skill for us to be able to learn. Not Ideally, we would like to have a rescue breathing mask like so. I would not recommend that you perform mouth-to-mouth breathing on a person that you are not familiar with. You are unsure of, what their medical history is. So I would not go ahead and perform any mouth-to-mouth breathing, but you can go ahead if you have a mask available. You can put this mask on and start the rescue breathing. Important thing to note about the rescue breathing is the seal that you want to have on the mask, or how you should appropriately fit the mask over the patient's face to be able to provide a successful rescue breath. You kind of want to have the patient's chin tilted back and their jaw elevated slightly. You want to have this EC grip on the patient. You want to have the C spanned over the top of their mouth, like from the bridge of the nose to the chin, and you want that E grip with your other hand to kind of rest along the bottom of the mask and their chin. So you create this really tight seal so you can give them the best breath possible. And what you want to do is administer one rescue breath over 5 to 6 seconds, or about 10 to 12 breaths over the span of a minute. All right, so back to our patient. So initially the patient had pulses, but they were not breathing well. So we did the rescue breaths and we wanted to reassess the patient, and we noticed that they lost pulses. What do? Freak out? No, because we are here as physicians in training, and we are well equipped with what to do next. So what should we do with somebody lose pulses? You can type in the chat. Absolutely. Perfect. So we want to go ahead and start CPR. So cardiopulmonary resuscitation, or CPR, is another extremely important skill for everyone, no matter what specialty you go into, to be well equipped with how to do this accurately. So CPR is a life-saving procedure, and it should be performed when someone's heart stops beating. CPR, as I briefly mentioned in the beginning of the lecture, that it can really increase the chances of survival dramatically 2 to 3 times. And you can imagine, if your heart's stopping, you're not really circulating that blood flow to the vital organs, including your brain. So the longer you wait from circulating the blood flow, the more damage it's going to have to your vital organs. So intervening and starting CPR right away is very important. So keeping this active blood flow, even just a little, really increases your success in achieving ROSC down the line. So just the basics about CPR. So there are 2 versions of CPR. What we do as healthcare providers, and you may have had access to, in medical school, is obviously the chest compressions. And when they say mouth-to-mouth breathing here, it means like you're providing breaths either with a bag valve mask, or if the patient needed to be intubated, and then you're providing breaths there until the ventilator gets there to provide the breaths for you. As a bystander, if you do not have a mask to help you perform the rescue breaths, then you should just do hands-only CPR. As I mentioned, you should not put your mouth on anybody that you do not know. If it's your very close family, like your significant other or your child, that is another story. You may feel comfortable at that point providing rescue breaths on them without a mask, but I would not do that on anybody else. So basics of chest compressions. So you want to push fairly hard, and you want to push deep. So you want to do at least 5 centimeters. You want to push fast between 100 and to 120 beats per minute. And a clever way that people know this, I don't know if you guys have ever heard of the Bee Gees and the song Staying Alive, but that's a song that people can kind of sing to themselves in their head to help you understand the rhythm and how fast you should be going. And another important thing about chest compressions, I don't know if you can see in the top right here, the positioning of this woman that's providing the compressions. As you can see, her shoulders are right over like the palm of her hands. So with her being able to do this, it provides more force onto the patient's chest to be able to provide the adequate depth that the patient needs. And it also will help you put less effort into giving the CPR. I've seen a lot of people who kind of do the CPR like this with their hands all the way out and they're pushing. First off, that requires a lot more effort to you to be able to push the adequate depth, and you're going to become really tired quite quickly. So setting yourself up in an optimal position is really important. And once you've started CPR, you should really do everything in your power to minimize any kind of interruptions. And as far as the compressions in adults, like I said, usually anywhere at least 5 centimeters, 2 inches in adults and children, and 1.5 in infants. So ventilations, you want to do 30 chest compressions to 2 breaths if the patient does not have an advanced airway. And if the patient is intubated, you're going to go ahead and do 8 to 10 breaths generally when the patient is intubated. And I think you guys have had a lecture on intubation, so I won't go into those details. So one of the takeaways that I want you guys to really understand is high quality CPR and the things that encompass high quality CPR. So that's minimizing any kind of interruptions with chest compressions. Again, as I've mentioned a few times, if you stop CPR, you're not circulating the blood flow to the vital organs, and really will kind of lead to devastating outcomes if you have multiple interruptions. You want to provide chest compressions with an adequate depth and a rate. So we said about 100 to 120 beats per minute, Staying Alive song, and the depth you want at least like 2 inches in adults and children. When you're providing between compressions, so you're doing the chest compressions and you're taking a break to give the rescue breaths, you don't want to be putting your body weight on the patient. That's, I think, mostly common sense. You want to make sure that your hands are in the appropriate place. So as you see this person here in the picture, you want to have your bottom palm. You want to do it like 2 finger breaths above the patient's breastbone, and then you can put your top hand over that. You can either interlock your fingers here, or you can put them straight and you use your palms to provide the compression. And you want to avoid excessive ventilation. So you don't want to be giving the patient too many breaths, because that will increase the gas inside of them, and that will again prevent like blood flow to the heart, because you're increasing the intrathoracic pressure. So you don't want to do too much of that. And just briefly on the AED, or the automated external defibrillator. So this is a medical device that you should use for a patient that goes into sudden cardiac arrest. The great thing about these AEDs, there's many different types of AEDs, but I think generally the principles are the same. I was pictured here what we see in the US. I'm not familiar with what's in Bulgaria, but the principle should be similar. Basically, you're going to apply the pads for the AED on the patient, and they'll be able to identify the heart rhythm that the patient is experiencing, and if it's something that would benefit from a shock to reset their electrical activity, it will instruct you to do so. Okay, so just the general steps for how to use an AED. So the first step is turn it on. I know it sounds really basic. They ask this question when we take our BLS training. They ask you, what's the first thing you want to do? And a lot of people forget to do the simple basics to turn it on. So that's the first thing you want to do, is turn the AED on. The next thing you want to do is obviously expose the patient's chest. Things that I didn't realize that when going through med school, obviously if the person was submerged in water and they were brought out and their chest is all wet and you're trying to put pads on, the pads aren't going to stick. So you want to make sure that the chest is dry. And so you can remove, the water with a towel. If the patient is extremely hairy, the pads won't be sticking appropriately. So I think the AED bags, they have a little, quick razor that you can shave if it's a gentleman who has significant amount of hair on their chest. You can go ahead and just quickly remove the hair before putting on the pads. And if you have a patient that has medication patches on them, you want to remove those patches before putting the pads on. So after you've attached the pads, you want to plug the pads into the connector. As you can see in the top right, the pads are attached to the white strings that are then inserted into the red box there. And so once they're on the patient, you want to push analyze. So the AED will then analyze the person's heart rhythm. And then it will prompt you to deliver a shock. If it does say that a shock is necessary, the number one important thing you need to advise anybody who's there helping you resuscitate this patient is to stand clear. If you don't tell them to stand clear of the patient, then they will themselves also experience the shock, and we don't want to end up having two patients here. So it's really important to tell everyone to stand clear. And once you stand clear, you press the shock, and then you immediately go back to doing CPR. So you're going to continue CPR and continue the efforts until the medics arrive. Okay, so back to our first patient, our gentleman that collapsed at the supermarket. Initially had a pulse, for which we did rescue breathing. He then lost a pulse, for which we started CPR. So we recognized that this patient had sudden cardiac arrest. We activated our emergency response system. We asked a bystander to go get us help. We asked the bystander to go grab an AED, and they called 911. We started our high quality CPR on the patient when we realized that they did not have a pulse. We applied the AED as directed, and we followed the prompts along the AED that recommended that we administer a shock. And after doing so, EMS arrived. They had intubated the patient successfully, and ROSC was achieved. So EMS had done a pre-hospital EKG that is shown above. That's concerning for a STEMI. So they had activated the cath lab pre-hospitally. Our emergency team was already aware of it at the hospital, and the patient was rushed to the cath lab, so we saved a life. So this is just an example of a case of how that chain of survival is really important, and early recognition and intervention can save someone's life. So great job, guys. We have saved our first life today. And just wanted to go over the basics of BLS. I know we just went through this, but this will be a quick review. So the first thing that we're doing is verifying scene safety. As you guys mentioned, we're checking the patient's responsiveness. We're gonna see if we're gonna shout for help, activate our response system, get the AED. If you're looking at the patient, look for the breathing to see if they're just gasping. You wanna check a pulse, and you really wanna make sure you can identify a pulse within 10 seconds. If you can't, you should go ahead and start CPR. If you see that the patient's breathing normally and they have a pulse, you can monitor the patient until the EMS gets there. If you notice the patient is not breathing normally but has a pulse, you can go forward with the rescue breathing as we said, and continue to check their pulse every few minutes to make sure that they still have it. If they are not breathing and they have no pulse, you can go to the next slide. Then we can start CPR as we did. You'll want to do 30 compressions to the 2 breaths. You want the AED to be applied as soon as we can. You're going to check the AED will check the rhythm to see if this is something that would require a shock or not. If it gives the shock, you continue CPR immediately, and you continue your CPR until the medics arrive. And if it's not shockable, you just continue the CPR. So another basic thing I wanted to go over quickly is just choking. So this is another common thing that we see in public. If you're out at a restaurant, that someone after eating will just start to develop some difficulties breathing. So choking is when a foreign object obviously gets locked in your throat and it kind of blocks your airway. So signs and symptoms, you'll see people, they're not really able to talk. They'll have difficulty breathing. They can have a bluish discoloration to their skin, their lips, their nails. They may lose consciousness, and they may have something called stridor. It's really squeaky, high-pitched breath sound. So these people will look very distressed. So what to do is the Heimlich maneuver for these people. I'm sure you've seen it on TV before, or maybe you've seen this in person, but just quickly to perform this, you want to stand behind the person that is choking. You want to wrap your arms around their waist, and then you want to kind of have the person lean forward a little bit. When you have your arms wrapped around them, you want to make a fist with one hand and kind of position that at their sternum, and then you want the other hand over that. You're going to press really hard and quickly into their abdomen and make like an upward thrust, as if you're trying to lift this person up. You want to perform this thrust anywhere between 6 to 10 times until the object is dislodged. So another tool for us to be able to save lives. So we have advanced from being a witness at a grocery store to now you guys are successfully matched into your emergency medicine residencies. You are on your ICU rotation, which is everybody's favorite, and you're rounding with all the attendings and the medicine residents, and you hear a code blue called overhead. I don't know about you guys, if you've ever heard of code blue or been in the hospital and heard when this has been called, but usually everyone kind of does a little bit of a panic for a second, just kind of like the Scrubs characters down here. You may want to run for the exit, which is what I wanted to do the first time I saw code. Anyways, so you're not like that. So you're gonna want to go to the patient's room. And what would you want to do when you get there to the patient's room? What are some things that you'd want to do?
You guys could use the chat box.
So just to give some context, a code blue in our hospital and most hospitals, I would say, is a cardiac arrest. Usually how it works is it'll be called overhead, and any physician that's part of the rapid response team will run to the room where the code blue is and kind of help resuscitate the patient. So perfect. Check vitals. Say so when you get to the room, the patient is there. They look like they do not have a pulse. They're not breathing. The nurse is just saying, "I don't know what to do. I don't have any vitals. I don't know what's going on." So you're there, and you need to lead the next steps. So the important things, I think somebody had mentioned in the chat, obviously, if you're concerned that the patient's in cardiac arrest, the first thing you can do is to start chest compression, CPR. Another important thing to do, a lot of times, unfortunately, these patients may be in an area in the hospital where they're not on a continuous monitor. So it's really important to attach them on the monitor, put a life pack on them in case they need a shock. And when you're there as the first person, you will be the team leader. A really important thing in running a successful code is communication. So you, as the physician, you are the team leader. You should assign people roles in advance. Codes can be extremely chaotic, but the more organized you start from the beginning, the smoother things will go on. So as the team leader, you're going to assign various roles. And when you assign people roles, you should kind of consider what their background is. For example, you're not going to ask the ED technician to be intubating the patient. That's out of their scope of practice. So you should be, obviously, if respiratory is paged to come to the code blue, they should be the ones doing the airway. So you're going to assign typically a nurse to do the IV, establish an IV, do an IO if necessary, administer meds. You want to have somebody be a timer or a recorder. As you've seen when we went over the basics of BLS, you want to check pulses every 2 minutes. So you want to have somebody recording how long it's been since pulses have been checked. You want them to tell you what meds have been given and when the next dose should be due. So having someone time and record is important. If the patient does not have any advanced airway, you want a respiratory therapist to be there to intubate the patient and then bag them if necessary. You want somebody to make sure that the pads are on and to work the defibrillator if there needs to be a shock administered, and you want to at least have a couple people compressing. So chest compressions can be very taxing after you're doing them for a while. So it's important to have at least, I would say 2 or 3 people there if you're able to provide these compressions, because you're checking pulses every 2 minutes, and you want to make sure that CPR remains high quality, as we had mentioned before. So they may need to switch out sooner before the 2 minutes, or at the 2 minute mark that you should switch a new compressor. So after we've got to the scene, we assigned our roles, we're starting CPR, so we now need to start advanced cardiac life support. So we're giving this patient oxygen, we're attaching the defibrillator, and then we're going to assess their rhythm. So I know that you guys have already had an EKG lecture, I believe, with Dr. Silverman, so I'm not going to go over it in full detail, VFib, pulseless VTAC, asystole, and PE. I'm just going to do the basics. So if you are at the scene and you believe that it's a shockable rhythm, meaning it's either VFib or pulseless VTAC, you want to go ahead down this pathway with starting with a shock and then CPR. And if it's it's either asystole or PEA, you don't want to shock, you want to continue with doing CPR. So back to our patient. So we established IVs, we're doing CPR, we hooked him up on the monitor, the patient has the life pack on, and this is the rhythm that we see. If based off of the prior EKG lectures, what rhythm are you thinking this would be, and what would you want us to do next? Yes, panic, absolutely. I believe JD could relate with you from Scrubs. So this looks a pretty irregular rhythm. It's wide, complex.
What type of rhythm does this look like, guys? You can write it in the chat box. There we go. Okay, good. That's the next step. Perfect. Defibrillation. Good. Why are we defibrillating?
Yeah. So the 2 options we had were pulseless VTAC or VFib. Perfect. VFib. Excellent. Great job. So this is VFib arrest. So shockable rhythms, just basics. Pulseless VTAC we see here. It's a monomorphic ventricular tachycardia. It's pretty regular. And then ventricular fibrillation will be very erratic, wide, complex, and extremely irregular. So you guys were right spot on. You want to apply a defibrillator and shock the patient. So it depends on the defibrillator that you have. Most are biphasic now that are in the hospital. So you want to go ahead and administer a shock. I usually start around 200 joules and then go from there. So medications, I'm just going to be brief for time's sake. So for shockable rhythm, yes, we shock the patient. We check at pulse check again. We are giving epinephrine. Epinephrine is huge. It's your best friend in cardiac arrest. You're going to do epinephrine 1 milligram every 3 to 5 minutes. A great way to do this is at every other pulse check. So if you're doing pulse checks every 2 minutes, that will line up. Every other pulse check will be at a 4-minute interval. So that's a great time to give epinephrine then. So you usually want to do a shock, and then an epi, you can give usually 3 shocks. And if they're not coming out of the rhythm, then you want to consider adding another antiarrhythmic on. And usually your next step is amiodarone. You can do a 300 milligram bolus at first. And if you need to repeat that, you can do a 150 milligram bolus. If you decide something, an alternative to amiodarone would be lidocaine, that you can start here. The first dose 1 to 1.5 mg per kg. Second dose is 0.5 to 0.75 mg per kg, and continue with the algorithm. So our patients say, so we intubated the patient successfully. The respiratory therapist did that. We are defibrillating the patient. We did that. We gave them 1 shock. We've given them 1 epi. We're at our next pulse check and we see this. What do we want to do now? And what rhythm do you think this is? Perfect. Compressions. And what are we thinking? Perfect. Yep. You guys are on top of it. Asystole. So the non-shockable rhythms are asystole, or essentially a flat line, and PEA, where the patient will look like they have a rhythm, but they will not have a pulse. So PEAs and asystole are non-shockable rhythms. So what we do in this scenario is continue with epinephrine every 3 to 5 minutes, and we'll do pulse checks every 2 minutes. And then really what we want to figure out is what are potential reversible causes of the PEA or asystole. So I don't know if you guys have ever heard of the H's and T's, but this is what we run through in our head as emergency providers when we see these type of arrest patients. So the H's and T's are all of the reversible causes and things that we can easily treat. So hypovolemia, they may need some more fluids, bring their blood pressure up. They may be hypoxic. They need to be intubated. This is a common thing for kids. Respiratory arrest is the most common cause of cardiac arrest in kids. There may be some metabolic derangements. They may be severely acidotic. Their potassium may be off, and you need to fix that. They may be really cold. They may have been submerged in a body of water in the winter. You need to aggressively rewarm them. They may have been a trauma patient. They have a tension pneumo. They also may have been a trauma patient or had some recent cardiac procedure and they have a tamponade. They may have had a drug overdose. They may have a PE, or they may have a heart attack. So just generally, before we go to the next slide, do you guys know of any, so aside from the blood work and checking their vitals, this can kind of help clue into what may be causing this. Are there any other like bedside tools that we could use to help kind of see if there are maybe some of these other causes going on? You may have had a lecture on it before. A quick bedside tool. We use it often in the emergency room to take a look at some of the insides. Yeah, perfect. Yep. So an ultrasound is going to be one of your best friends during a cardiac arrest. It can help you kind of cross some of these H's and T's off. Especially, you can take a look at the heart, see if there's tamponade. You can take a look at the lungs, see if there's lung sliding, and if not, it may clue you into a tension pneumothorax. You can, again, with looking at the heart, you can see if there's evidence of right heart strain, and there's a PE, and you can look and see if what the cardiac squeeze looks like, if there may be evidence of ischemia to the heart. So ultrasound will be your best friend. So back to our patient. You are a rock star EM intern. You not only are leading the code successfully, but you bring up the idea of the ultrasound. You do a quick ultrasound of the patient's heart and you notice this. What do you think this is and what would you want to do next? So just, I don't know if you're familiar. Perfect. Yep. So there's cardiac tamponade. So that is the cause of our patient's arrest. And what can we do to help in this scenario? I don't know if you got perfect. Pericardiocentesis. Excellent. Yes. So on our next slide, yes, you identified the tamponade, and the correct way to treat this would be a pericardiocentesis. We won't go into any details on how to perform this, but essentially you're putting in a needle safely directed at the heart to remove all this fluid that's preventing the heart from appropriately contracting. So awesome, you guys saved another life today. We're extremely happy. After we performed the pericardiocentesis, our patient now ROSC is achieved. So just a little bit about ROSC, the important things. So it's the return of spontaneous circulation. It's really important because to maintain appropriate perfusion after you've achieved pulses. One common thing that I see is people let the patient be slightly hypotensive afterwards, and again, that's another factor. One of the H's and T's can cause them to go back into cardiac arrest. So you really want to be mindful of their blood pressure and making sure they're perfusing. You want to make sure their oxygen levels are normal, that they're not cold. If they have a heart attack, that they should go to the cath lab and receive PCI. Make sure their blood sugar is in check, and you want to minimize any kind of irritation to the patient. Okay, awesome. So you guys did fantastic. We saved 2 lives in the span of 40 minutes. We went through all the high yield aspects of BLS, ACLS. I think you guys are well equipped to save any person's life that comes your way and needs some life support.